My name is Dominik Dytfeld. I'm hematologist working at University of Medical Sciences in Poznań in Poland. And I had a great pleasure to present the results of the ATLAS study during the last ASCO and the EHA meeting. And what I'm going to do to present the same presentation that I did during the last EHA, again to share the results of the ATLAS study. So it's my great pleasure to present on behalf of all co-authors the results of the ATLAS study, which is a phase 3 randomized trial comparing carfilzomib, lenalidomide, and dexamethasone to lenalidomide maintenance after bone marrow transplantation in patients with newly diagnosed multiple myeloma. The study is being coordinated by the University of Chicago and with close collaboration of Polish Myeloma Consortium. This is a joint effort of Polish and American researchers listed here on the slide. Here are my disclosures. And now, the rationale behind the ATLAS study was to investigate if the extended carfilzomib, lenalidomide, dexamethasone, so in short, KRD, can improve the results of the lenalidomide maintenance in patients with newly diagnosed multiple myeloma, which is an established standard of care. The extended KRD treatment after KRD induction followed by the bone marrow transplantation is associated with long progression-free survival and suggests the benefit of extended post-transplant KRD. Additionally, the outcomes of the fourth study comparing KR to R maintenance provides an additional support of benefit of extended KR treatment. In this still ongoing phase 3 randomized study, we directly compare post-transplant KRD to lenalidomide maintenance in patients with newly diagnosed multiple myeloma. Here you can see the study design. On the left, you can see the key eligibility criteria, which are very similar to CLGB lenalidomide versus placebo maintenance trial. We enrolled patients who had at most 2 lines of therapy, who had bone marrow transplantation no later than 100 days before the enrolling the study, and those who had no progression at any time. Patients were randomized in 1-to-1 ratio based on the post-transplant response and cytogenetic risk. Here in the middle, you can see the KRD dosing and schedule. For the first 4 cycles, carfilzomib was given at the 36 milligram per square meter twice a week for 3 consecutive weeks out of 28-day cycle. Afterwards, carfilzomib was given every other week. Using MRD directed risk adapted therapy, carfilzomib KRD was terminated after 8 cycles in patients who were in standard cytogenetic risk and who achieved MRD negativity at cycle 6. After 8 or 36 cycles of KRD, patients receive lenalidomide maintenance and monotherapy until disease progression or intolerance. Lenalidomide was given first at 25 milligrams a day for 21 days, dexamethasone 20 milligrams once a week. In the control arm, lenalidomide was given at 10 milligrams a day for first 3 cycles, and then, if well tolerated, at the dose of 15 milligrams a day until disease progression or intolerance. The primary endpoint was progression-free survival, counted from the randomization. Secondary endpoints are listed here also on the slide, with MRD negativity rate at cycle 6 which is crucial for the study design and further treatment modification. We enroll 180 patients as per study design, 92 patients from the KRD and 86 patients from the R arm were evaluable. Out of patients treated with the KRD, 34 of them who were in standard cytogenetic risk and who achieved MRD negativity at cycle 6, the KRD was de-escalated to lenalidomide maintenance after cycle 8 until disease progression or intolerance as in study design. Here you can see the patient characteristic. They were well balanced between both arms. Around 90% of patients were at VGPR at study entry, 23% and 21% in respective arms were in high cytogenetic risk. Vast majority of patients were treated with VTD or VCD as an induction. Of note, 68 and 60% of patients were treated with thalidomide, 11 and 13 with lenalidomide, and 4 and 6 with carfilzomib in respective arms during the induction. After a median follow-up of 33.8 months, the median progression-free survival for the KRD arm was 59 months, while on the lenalidomide maintenance arm, 41.1 months, with 44% of reduction of risk of death or progression favoring KRD. Subgroup analysis shown in this forest plot suggests a superiority of the KRD over R arm in majority of analyzed subgroups. Of note, in some of the subset, number of events is still low. The percentage of MRD negativity at cycle 6, according to IMWG criteria, defined as MRD negativity with sensitivity with at least 10 to the minus 5, and achievement of complete response was 44% for the KRD arm and 27% for the R arm. It reached the secondary endpoint of the ATLAS study. On the right, you can see the percentage of minimal residual disease negativity based on the NGS at cycle 6 with sensitivity with a 10 to the minus 5 and 10 to the minus 6. Since our study used the MRD directed risk adapted study determination for patients with standard risk, here I show the results for the standard risk population. On the left, you can see the percentage of MRD negativity at cycle 6 for standard risk patient, which was 44% for the KRD and 26% for the R arm. Progression-free survival was significantly longer for standard risk patients treated with KRD over the R arm, with 56% of reduction of risk of death or progression favoring the KRD. Focusing on patients who were in standard cytogenetic risk and who achieved MRD negativity at cycle 6, we observed 77% of reduction of risk of death or progression favoring KRD over R arm. As a reminder, those patients here on KRD were patients at standard cytogenetic risk who achieved MRD negativity at cycle 6, and after cycle 8, the treatment was de-escalated to lenalidomide maintenance. Overall survival shown on this slide is relatively early. After approximately 3 years of observation, there were 9 deaths on the KRD arm and 11 on the R arm, and there was no significant difference between the overall survival between KRD and our arm. The treatment was well tolerated in both arms. Here we show the grade 3 and higher most common toxicity and toxicity of interest in both arms. In general, they are similar to previously reported and comparable between both arms, with slightly higher percentage of neutropenia for the R arm and slightly higher percentage of the infection in the KRD arm. Focusing on the toxicity of interest, there was no difference in terms of cardiovascular and neurological toxicity between both arms. As a conclusion, the ATLAS study is the first randomized phase 3 trial which could indicate superior progression-free survival with extended post-transplant KRD therapy compared to the lenalidomide maintenance. MRD-directed, risk-adapted KRD maintenance is potentially more effective alternative to lenalidomide maintenance and may represent a new standard of care. I would like to thank to all our patients who participated in the study, their families, and all staff members at the involved sites. Thank you for your attention.